Thank you, Corey. And now, again, I mentioned that normally at this point, we would be asking our elected officials to come forward and explain their committee thinking in the upper house, the Senate, in the Committee of Health and Welfare, but regrettably, not one of them was here to address you and answer your questions. So next we're going to go to Dr. Fred Charisse, okay? Fred's a frequent flyer at our tables and a good friend to Leaders with Vision. He is going to address the taxpayers' financial impact. Fred?
Thanks, Gene. So listening to the conversation, I thought it'd be helpful just to step back for a second and give a little perspective. You know, in Louisiana, we have somewhere around 750,000 people who are uninsured. Why is that important? What does it mean to be uninsured? I know Dr. Ralston is going to talk about that, but there's data out there that says people without insurance have poor health outcomes. They're more likely to die when they're admitted to the hospital with a heart attack or heart failure. We had a patient in one of our hospitals not long ago who was admitted to our hospital in Independence, Louisiana, needed a neurosurgeon, could not get a neurosurgeon there, obviously, in Independence. At that small hospital, our medical director called 17 hospitals that day, including our large hospital in New Orleans, which couldn't take that person because they had 7 people waiting in the emergency room for an ICU bed that day. Finally, at the end of the day, the patient was transferred to our hospital in New Orleans, but it was too late and the patient died. This is the story of being uninsured. There are a lot of data. Facts say about 45,000 people a year die in the U.S. as a result of uninsurance. It's not an abstract number. What does it mean to have Medicaid? Well, Medicaid, we know, will provide better access to care. There are data to show that Medicaid will reduce mortality. It increases the detection of cancers at a treatable stage. And importantly, it reduces the impact of catastrophic health expenses for individuals. And so in Louisiana, this expansion, the opportunity presented to the state would expand Medicaid to around 400,000 people in the state. As Calder said, the Supreme Court ruled and said the federal government can't force states to accept the billions of dollars in federal money to provide health care coverage to people through Medicaid. And so as a result of that, we have an expanded Medicaid in Louisiana. Let's talk a little bit about the fiscal impact, because you'll hear this argument that we just can't afford to cover more people through Medicaid. There have been a number of analyses looking at this. The one I like to refer to, because it's an independent body, is the Legislative Fiscal Staff. Their analysis showed that over 10 years, the state would actually save money somewhere on the order of $185 million to about $510 million over 10 years the state would save as a result of this expansion. And that's because the federal government would pay in the initial years 100% of the cost. That tapers off to the year 2020 when the state would have to contribute 10% of that cost. But there are a lot of offsets that the state would gain. Populations that the state now covers and pays for with state funds that would be eligible for the Medicaid program. Savings that the state pays for through the uninsured now that it would not spend. And so the fiscal staff said the state would save up to $500 million over 10 years by participating in the program. It wouldn't be a cost to the state. DHH Calder's group said the state could save $387 million. The range would be saving $387 million to spending $1.7 billion over 10 years by participating. So potentially savings. The cost was largely due in that analysis to the assumption that the state would pay up to 100% of Medicare rates, higher rates in the Medicaid program to doctors and hospitals, which this department has never shown a propensity to do. But that's built into the set of assumptions. And interestingly, last session, the legislature passed a law that will go to the voters next November, where if approved, the hospitals will get paid at that 100% Medicare rate, and it won't cost the state additional funds to do that because they're going to tax the hospitals to do that. They will take that tax revenue, turn around and match it with federal Medicaid money, and then pay those hospitals up to their Medicare rate. And so the largest part of that $1.7 billion cost would actually not be a cost at all. And I think that it's an interesting point that the administration is neglecting to talk about. I'm not sure where the $7 billion state fund over 10 years. Oh, okay, 1.7, not 7 billion. So that's the 1.7 billion, and it doesn't even account for things like the fact that we know there would be savings that we can count. Prisoners right now that are paid for with state funds would be paid for through Medicaid funds with this. A number of savings for the uninsured. Doesn't count the taxes that would be generated by spending $16 billion of federal money in the state. Other states have done these analysis and show that state and local taxes of upwards of over $100 million a year would be generated with this additional federal spending. So I think clearly it's not a cost, it's a savings to the state to participate. So you have to move to other arguments and try to understand why the state won't participate. One of the ones that has been remarked on is that 40% of the population will now be in Medicaid, and as the governor said, more people will be in the cart than pulling the cart. The fact is 35% of our population makes below 139% of the federal poverty level. We have a poor population, which is why if we don't cover that group through Medicaid, they will not be able to afford insurance. And so you'll see a situation where people that work in the state, like the governor, who may participate in publicly funded insurance, kind of in the cart, if you will, for your insurance, whereby the people that clean the offices don't make enough money to take advantage of the state subsidized insurance, and so they won't have access to health care, would gain access to health care through the Medicaid expansion, but because the state's refusal to participate, we'll have somewhere around 240,000 people a year who won't be eligible for health care through Medicaid and won't be eligible for the federal subsidies because they earn too little, believe it or not, to be eligible for the subsidies. Because the subsidies start at 100% of the federal poverty level and go to 400, because it was always assumed less than 100 states would cover through Medicaid. But when your state doesn't participate, those people under 100% get left out.
Do you want to answer that, or do you want Mike to answer it?
We'll go to Mike.
Oh, thanks.
Thank you. I'll answer it if you want me to. What's it say? What would be the cost?
Cost benefits. What would be the cost versus the benefits?
Well,
healthcare, if you were proactive rather than reactive.
Well, that's the fact is prevention costs money. I'm sorry. What would be the cost benefit of being proactive rather than reactive in healthcare? Spending more money up front than spending money in emergency rooms and things like that. I think most preventive things we do actually cost money. There are a few preventive measures, vaccinations and such, that are very cheap to do and on a large scale can actually save money, but most things cost money. The benefit is it keeps people healthy. It's good for people. And so this is a program where the federal government is attempting to give the state billions of dollars to cover your people to provide better health care, and the state is not participating. So the state's foregoing about $16 billion over 10 years, an opportunity to make people healthier.
Okay.
Thank you.
And I wanted to add, from a business point of view, when people are healthier, they are on the job more often. Okay, and our next person is going to be Dr. Mike Rawson, and we thank him very much for giving time out of his practice to come today. He is here to give the perspective of the uninsured. Mike, come on up. And you can finish answering this question if you want to add to it.
I'm very excited. Thank you, Gene. So my head's kind of spinning after all that information, and I really feel like I belong more in the audience than up here. I have more questions than I have answers about all this. So like you, I have a lot of questions about healthcare expansion and access and a lot of concerns about it. I think that the number of uninsured in our state's already been referred to, and it's somewhere in the range of 20%, would be probably a good number of our population has no insurance, and that's a staggering number. But I think that it's also important to pause for a second and recognize that lack of insurance, or I'm sorry, having insurance is not the same as having access. So people say we want to improve access and we want to give more people insurance. Access and insurance is not the same thing. I'll give you an example. In Massachusetts, that several years ago went to universal healthcare. Everyone has insurance in Massachusetts now. They had, prior to that, the highest percentage of physicians to population of any state in the country. So they had more physicians available to them. And with the increased number of people who have insurance, access has decreased tremendously. So the number I read this morning was that it currently takes 50 days to get in to see an internal medicine doctor, and over half of internists are no longer accepting new patients. So just because you have insurance, whether it's Medicaid or Blue Cross, doesn't mean you have access. It's an important problem to be aware of. Having said that, just because you don't have insurance doesn't mean you're not going to get taken care of. And there's two reasons for that. Particularly here in Louisiana, we're kind of good, warm-hearted people. We care about each other, and we take care of our fellow citizens. People are not going to die on the side of the road without being taken care of. Now, the federal government stepped in and kind of legislated that a few years ago with what's called the EMTALA legislation that requires hospitals to take care of and treat people that show up in the emergency room. So if you show up in the emergency room and you have no insurance, you're still going to get taken care of, which has created a situation of people using the emergency room for their health care. If you don't have insurance, have no money, you have a sore throat, go to the emergency room and you'll get taken care of. It's not really an emergency, but that's how it's done. Kind of as a result of that, after Katrina, we had a large influx of uninsured patients in the Baton Rouge area, and our public health care system, which already was pretty much at a breaking limit, was totally overwhelmed. As a result of that, we formed a group called Volunteer Health Corps. It's a large group of doctors, nurses, social workers, physical therapists, and students in Baton Rouge who work to try and extend some of this care to the uninsured. It's a small group, and it makes a small dent in the large problem we have. But we'd like to kind of use as a springboard for a discussion of this kind of a story. So, again, I work some with VHC, Volunteer Health Corps. The way this works is on Tuesday nights at 6 o'clock after you work all day long, the people who volunteer go work at a clinic and see patients who are referred from either the hospital or emergency room with a problem. And typically, someone will be in an emergency room with high blood pressure or diabetes, poorly controlled. They're given something and told, you need to go see a doctor. Well, they don't have any insurance or money, and what do? They go back to the emergency room to get taken care of. So we agreed to see these people in Volunteer Health Corps. So Tuesday night a few weeks ago, I saw a lady, she's about 32 years old. She works at one of the hospitals here in town, but couldn't afford the insurance. She has diabetes, but couldn't afford the medication. Started feeling bad at work and was sent to the emergency room where they said your blood sugar is 400. They gave her some insulin, they brought it down. They gave her a prescription for medication, sent her out and said, go see a doctor. Again, no insurance, no money, so she came to Volunteer Health Corps, and we saw her on that Tuesday night. I checked her blood sugar that night, it was 400. I said, are you taking your medicine? She said, no, they gave me a prescription, and it was $300, and I just can't afford that. So we were able to give her a prescription for something less expensive, and at that point, we had her come back next week, and her blood sugar was controlled. I was able to give her a note saying you can return to work. They would not let her go back to work without a note from a doctor, and she couldn't afford to see a doctor, so she couldn't go back to work. So it's this vicious cycle that patients get caught up in with all kind of problems like this. But again, we were able to help take care of her. Probably 90% of what we see at Volunteer Health Corps is the two chronic diseases of diabetes and high blood pressure. And again, they go to the emergency room. Before Earl K. Long closed a number of years ago, part of our action with VHC, I actually called Earl K. Long and said, hey, I'm new in town, I don't have any insurance, and I have high blood pressure and diabetes. I need to get my medicine refilled. Can you get me into one of the clinics? And they said, no, sir, our clinics are full. We're not taking appointments. I said, well, how do I get on a waiting list? We don't have a waiting list. I said, how do I get my medicine refilled? They said, go to the emergency room and wait there, and someone there will give it to you. So actually, we're telling patients to go to the emergency room. Currently, it's over 1,000 patients waiting to get into the LSU clinics right now. And so if you're left from the hospital emergency room and you're discharged, you can't get back into the clinics to be seen. So if you have no insurance, the public health system currently is not capable of seeing those patients. And again, Volunteer Health Corps is a very small group. We're not making a dent in the problem. It's just an example of one of the things going on. I will kind of answer Gene's questions I couldn't read earlier, a bit about preventative. If we don't take care of these people with high blood pressure and diabetes, they'll have a stroke or a heart attack or get kidney failure. And then once they have that, they're eligible to be cared for by all of our tax dollars for years and years with all the complications from the disease that we didn't treat adequately at the beginning. So It is a very, very complicated problem. I know it's a problem. I don't know the answer, but I do think we have to improve the ability of all of our citizens to get some type of health care.